everybody. Thanks for giving me the opportunity to talk here. I'm a veteran of the pharmaceutical industry. I'm a newcomer to the cannabis arena. I'm going to talk a little bit about trying to close the gap between well-established pharmaceutical industry and going to oral absorption and drug delivery systems of cannabis. So practically, the status today, even in Israel, that cannabis medicine for most patients still involves the black market with the myriad risk and the inherent lack of quality control. So Doron, why do you say that? I mean, go to your car, make the application. So that's what happened to me. A week ago, one of my neighbors came to me and told me, my daughter had a severe migraine for 10 years, and she was twice hospitalized because of conventional medications, over medications. She has a terrible life. We haven't seen any future for her. And she occasionally went to India someplace and tried cannabis recreation, like many youngsters, and she came home a different person. So for about 2 years, we are going from physician to physician. Nobody was willing in Israel the last 2 years to give this lady a medicine until she went to a specific physician in Jerusalem. I'm not going to say the name. And he gave it. Now she's getting it by permission, by a car. And she's totally different life. And I have about 4 SMS from her from yesterday. She's collecting for me one of a couple of 10 or 20 colleagues of her, youngster patients with cluster headache, migraine, and trying to fix and settle down, let's say, a base to know what they get. I asked her, who is dispensing to you? And she gave me the name. I talked to them this morning. And what type you get? THC, CBD. So it's really fascinating. It happened yesterday. I was sitting here in the parking lot for half an hour talking to this wonderful lady, the age of my kids. So the future is really, the desirable alternative will be safe and effective, evidence-based pharmaceutical solution that physician and prescribe with confidence. That's what we want. That's what brings me here into the cannabis arena, and I hope to contribute. How do you want to take your medicine? I'm talking about this short presentation about oral delivery system, gels, or capsules. And of course, the oral administration of medicine is the most convenient and preferred mode by most patients. And really, this industry is evolving and maturing, and it's time to give some attention and insight to the cannabinoids delivery system and the pharmacokinetics, PK, versus pharmacodynamic, PD. What is PD? PD is what the drug, let it be cannabis or whatsoever, does to your body. PK is what your body does to the drug, how it's absorbed, secreted, metabolized, etc., etc., etc. These two has to come together into the consideration. We are talking on drug delivery system, but here is something more complicated, because in regular medicine, you have your API, you purchase it, you synthesize it. Here you have to deal with the grow, with the, well, it's too small for me, for the extra purify, test, formulate. You can skip nothing. Each one of these is a chain until you come to the final delivery system. You can't skip anything. And I think these are in the audience here, it's the right people that are dealing with all the aspects of, and this conference, we've seen aspects and many exhibitions about purifying, extracting, testing, formulating, doing all the way along. Sorry to, regret, really. Bioavailability of cannabinoids are low in any mean, and you're going to have a lot of figures because there is not enough standardization and not enough real scientific work to tell you exactly. Because if you do an inhalation and then you have a couple of studies, one in California, one in India, what is the drug? You talk to the people, I don't know, I got it from the grower. I don't really have standardization. Can I change? You took a picture? I can share later on with somebody. So let's dig in on the routes of drug and, of course, cannabis delivery. And what you see here, the oral, of course, is the slowest. It has to go you have to ingest it. It has to go some way into the GI tract, and then it's absorbed. So you have a medium-long duration, and the first pass is 100%. Everything is going by the first pass, by the liver. When you go by inhalation, you have none. But you have a very fast but short activity for these migraine patient, for psychiatric patient, anxiety. What do you want them to use it 4, 5, 6 times a day? So I talk to physicians. They tell me these are not stable people. Give them once a day. That's a big challenge. I took the challenge. Transdermal, of course, it's very long and of course, let's talk intravenous. Intravenous is the fast and short. Now, it is the base. Everything is, all these numbers and all the discussion is in relation to the intravenous. Okay? That's a lovely picture I've seen in the net. I don't know, it belonged to somebody, so you can have it later on. And as I told you, the pharmacokinetic and the pharmacodynamics are not the same story. Finally, what is interesting to us is not the concentration, is not the pure PD or PK, but we are interested in the effects over time. This is really what's interesting to us. But we have to control and understand these, the PK and the PD, in order to come up with smart solution and better solution. Let's go very fast on some facts that you all know, that after the typical plasma level, after THC smoking, is 70 to 160 nanogram. Because it is lipidic, it's going very fast into the bloodstream and disappear into the fatty tissues. When cannabis is smoked and inhaled, only about 10 to 25 is absorbed, and only 1% cross the blood-brain barrier. Of course, everybody knows why it's so important. However, after the patient stops inhalation, the levels drops down very fast, and so you have a very short activity. When ingested, it takes some time to the effect to come into to maturation, to really have a good effect, 2-3 hours to the peak, and then you can have a very long effect. The bioavailability, as I told you, regret to tell you, it's very, very, very low. Why it's very low? Okay. Let's look at a little bit on the bioclassification. Has anybody have ever seen the bioclassification system or familiar with the bioclassification system? Okay, that's so simple. Any drug you know, any drug you can imagine you ever met, goes into one of these 4 groups. So simple. Once people struggle with PK and a lot of mathematics and algorithms, nothing. You have a high solubility, high permeability drugs, type 1. You have a low solubility but high permeability. You have high solubility, low permeability, and you have all these drugs with low solubility, low permeability, cannabinoids. So let's see some examples, like paracetamol, class 1. Whatever you do, you take it in ethanol, small particle, large particle, it doesn't really matter. It's so difficult to change the PK because it's completely soluble in the GI medium, and it's well absorbed. So formulation has nothing really to do. You go to nifedipine, which is an oily substance. Wow, it's difficult to formulate. You put it in oil in a soft gel capsule. Absorption is good, okay? Low solubility is in oil, but high permeability, everything is fine. You have 35, 40, 50% absorption. Everybody's happy. Now you go to captopril. Okay, you go to captopril. Now you have a high solubility, is well soluble, but permeability is very low. It happens to be the captopril and all ACE inhibitors have a very strange absorption pattern, is nonlinear, and I published a couple of papers about the mode of absorption of ACE inhibitors in the 90s. I forgot to put the reference over here. That's my work in the postdoc with the person that drafted this classification, Professor Emmett in Ann Arbor, Michigan. Everything is very mathematics. You see, that's what happened when it's a very strange situation. They brought a mathematician to manage the pharmaceutical, the School of Pharmacy in Ann Arbor, Michigan, Professor Amidon. And he's talking about numbers. how many ml you need to dissolve the dose. I mean, we're talking about mathematics. We are not talking. This is the time I left or time I'm talking? Left? Okay, so I was sure I'm talking 2 minutes. And I took okay, so what do you do with such naughty drugs? They are not absorbed. Cyclosporine was the first immunosuppressive agent that enabled 90% of the transplantation all over the world from the last 40 years. So you do self-emulsifying systems. And you see a couple of huge blockbuster drugs, Neural, cyclosporine, or Novartis, and other drugs. And that's exactly what is right now done for cannabinoids. For example, if you take some of G therapeutics and Epidiolex in sesame oil. So just you take your drug, dissolve it in oil, and you have a lipidic delivery system. And then you add some surfactants, and then you can come to nanoparticles, self-emulsifying nanoparticle, and many sophisticated delivery systems. All of them have potential to increase absorption. By potential, you have to show by an experiment. And all these lipids have a unique mechanism of absorption. They have a potential to bypass and go to bypass the first pass and go directly to lymphatic absorption. That is the great advantage of this lipidic delivery system. There are plenty of sophisticated delivery systems, liposome, micelles, and solid lipids, many types. And that's what any delivery system has to tackle, to cross by and to be absorbed. There's the reason this methodology and the concept of oral absorption is so complicated. Two of my kids are engineers. They told me, can't you do something in silicon to make this calculation? Why you work so much in the lab to make so much experiments? Can't you simulate this process? Not yet. Maybe somebody will do. First of all, I'm making a living out of this. So I told them, just wait another generation because you simulate. And all these particles sometimes can cross the GI barrier as they are. And there are plenty of evidence to that, not in huge numbers, but you can come up to a couple of percent. And here are some types of mechanism of drug absorption. Any dosage performed has to be communized and make it to come up with a very small particle that can be dissolved, and then it can cross the GI barrier and be absorbed, or they go into special particles. So, I have 2 minutes. So I want to talk a little about okay, what's going on? What's going on? So I'm going to now show a set of slides I collected from the net. BG, before Google and after Google, AG. After Google, everything is on the web. You can go, so CBD, and it's written over here, increased bioavailability. And you dig into the site and you want to know, okay, what is increased bioavailability? How much? Okay, this is the gel pen and Sativex. Well, absolutely, there is increased bioavailability. How much? Very difficult to say. Let's say, I don't know, 40% increase? Twice? No, it's not twice. When you go to the gel pen 10 in comparison to 100 milligram, the area under the curve of the 100 milligram is not 10 times, it's much higher. Why? What happens there? Maybe it's saturation of the first pass enzyme metabolism. What's going there? I don't have an answer to give you, but it's a lot of stuff to think about. And that is another technology published by this company about nanoparticles, a lipidic delivery system. Here you see a dramatic area under the curve increase by this technology. And then they published some human studies, very, very nice, very fascinating. This is a patent from, well, I don't have the year, what is it? 1999. And here the THC was either given by MCT oil, made in triglyceride coconut oil, or given in TPGS, tocopherol polyethylene glycol succinate. It's a surfactant approved for food and in oral delivery system. You see a very nice increase in the area under the curve. Here's another technology published half a year ago. They say bioavailability, unprecedented high level. Here's the solubility. Don't be mistaken. They published the solubility. Solubility is excellently increased, but still, they have to prove. This company, high bioavailability supplement. Does anybody have seen any data about the increase of bioavailability? Please help me. I haven't seen it on the net, and I really appreciate it. Maybe I missed. Oh, I like this CNN. This is the most powerful. This is my edition. That's not from the CNN. But this is the most powerful. I don't know what's powerful. I mean, can you just show me some data? I mean, what's the amount you increase? This is another company. I'm the end of my time, so I'm ready to. I'm really to share some other. No. Just a second. Okay. So now to summarize. I have 20 seconds to summarize. Is there a pathway that will lead to return of cannabis to mainstream medicine? Yes, of course. The answer is clear, in as much as it has already commenced and follow. And we have to provide a process of pharmaceutical must attain the received regulatory approval. We have to, it must also possess the practical and suitable delivery system. So we have to come up with serious science. Let's do a good science, and then we'll be in good position. Don't rush. Don't go to the stock exchange. Do good science. That's my advice. Do a good PK/PD studies, novel delivery system that will provide the patient with the best and patient compliance medicine. Thanks so much.
Thank you.